As far as estrogens go, estradiol is the major natural estrogen. If we want to supplement or use hormones that exist in the body, we need to chemically alter them to help in their pharmacokinetic, particularly to make sure that they have a long enough duration of action. So that's the idea of making synthetic form of these hormones to increase oral bioavailability, which otherwise is pretty tough for most hormones, increase their half-life. And as you use estrogen, the whole idea is to have a potential feedback inhibition of FSH and LH. Now, when you look at the estrogens, there are several forms. The natural form is actually isolated from urine of pregnant mares. It's called Premarin. That's the trade name. So they're conjugated equine estrogens. Otherwise, you'll always recognize est in the actual drug. Look, ethinyl estradiol, mestranol, diethylstilbestrol. So you'll never have a problem, I think, to recognize this is an estrogen-like molecule. What are uses of estrogen? They can be used as a supplement in female hypogonadism. Remember, female hypogonadism could happen secondary to Turner syndrome, for instance, if you wanted a genetic form, that is. They have been used in hormone replacement therapy, HRT. And when they use in menopause in hormone replacement therapy, generally, as we'll see in a minute, it's together with progestins to oppose them a little bit. They have been used as part of the oral contraceptive pill in dysmenorrhea, in uterine bleeding. They've been used as far as acne management. And if they're used in a male, it would be at high doses in prostate cancer, but we have better drugs than this, and that would be to try and do a chemical castration, basically. General side effects of the estrogens are particularly of importance the potential of hyperplastic changes in tissue, not only in the endometrium, but certainly also in breast tissue, and that is in both ducts and lobules. You know where we're going with that, don't you? We're going to start worrying, does this hyperplasia induced by estrogen used as drugs increase the risk of cancer the same way as it does in pathology with the natural estrogens? That is the idea of unopposed type of estrogen. Well, if we turn the page, unfortunately, you bet that's what we're going to check out. The issue of thrombosis in pathing is only at very high doses. Estrogens can actually cause the liver to make more clotting factors. So really, at the doses that are classically used, it's not so big of an issue unless the lady or the patient in general has a pre-existing risk of thromboembolic disease. But when it comes to the cancer risk, now that's an issue. There is now well-established increased endometrial cancer risk, and that is why we need to oppose the estrogen with progestin. Issues with the breast cancers are still considered questionable, but pathology really indicates that unopposed estrogen can increase that risk. You know that even certain surface epithelial tumors of the ovaries may have an actual link with unopposed estrogen. So as such, this is the biggest worry. Adding progestin should get rid of this potential risk of cancer. How about the story of diethylstilbestrol? Well, it is still board tested as the idea that during at-risk pregnancies, when mom was taking diethylstilbestrol, she actually ended up increasing the risk that her daughter would later on in life develop clear cell adenocarcinoma of the vagina. And that teratogenic effect, my friends, you'd better remember it. Classic board question of both path and pharm. As far as other drugs that deal with the estrogen pathways, well, there are drugs that are used in cancer treatment. And these are important drugs that if you want, you could all move to your cancer chemotherapy chapter. Anastrozole is a drug that will inhibit estrogen synthesis by working on the key enzyme aromatase. Aromatase is this enzyme we find particularly in fat tissue that can take androstenedione from the adrenal cortex, make it estrone in the adipose tissue, and down the road allow the formation of estradiol. So the use of anastrozole has been to prevent estrogen synthesis and to fight estrogen-dependent postmenopausal breast cancer. The problem with anastrozole is that Tamoxifen came on the market pretty much at the same time. And you know the story. Tamoxifen has become the drug for estrogen-dependent postmenopausal type of breast cancers. Before we look at tamoxifen, here's another drug that has to do with estrogen, but not cancers. It is the drug clomifen. Don't confuse clomifen with tamoxifen. Clomifen is when you want to have 20 kids in 5 minutes. It's the fertility pill. This is a drug that is going to decrease feedback inhibition of the endocrine axis, causing FSH and LH surge. And let's not forget that if FSH matures the granulosa layer, LH is the one that will trigger the ovulation and result in pregnancy. That fertility drug is undoubtedly very well mediatized as causing increased multiple birth risk. Contrast. Tamoxifen, raloxifen, which are so commonly seen at the same time because they're structural analogs of each other. Well, these are part of the group of drugs we call selective estrogen receptor modulators, or SERMs. Tamoxifen is really, in a way, a partial agonist of estrogen receptors. As such, expect duality. Expect that the drug, when it is by itself in a tissue that has receptors, it can stimulate, but it will never stimulate with a maximum effect, rather with a ceiling effect, a partial efficacy. On the other hand, in presence of endogenous estrogen, it will block their action. It will behave as an antagonist. Tamoxifen then has variable actions depending on the target tissue. As an agonist, antagonist, partial agonist, we need to wonder, when am I going to use it? Where am I going to use it? It is used for estrogen-dependent breast neoplasia. It is powerful enough and safe enough as a hormonal drug to be used even in prophylaxis. You remember the major risk factor for breast cancer is to have a first-degree relative with breast cancer, that is, mom or your sister. And as such, it allows the prophylaxis, if it's estrogen dependent, a good decade prior to the onset of the actual tumor. Well, the problem with using a drug that's a partial agonist, postmenopausally, once it gets into endometrial tissue, it will behave as an agonist. And a worry has been that it might possibly increase the risk of endometrial cancers. So it's something to follow, of course. Right now, the benefits definitely outweighs the risk. But let's think in terms of the bone 1 second. A postmenopausal lady has osteoporosis, quite likely. And that was the whole basis in part of hormone replacement therapy, besides the cardiovascular risk from the high LDL when estrogens are not present. If you're a partial agonist, you should be able to prevent osteoporosis. And you don't have to say this too long for the drug companies to come up with raloxifen, another SERM that is used as a prophylaxis of postmenopausal osteoporosis. And when it's used in menopause right now, there is that thought that there is no increased risk of cancer. I say to you, let's wait until there are enough decades behind raloxifen to see if this is true. The logic would be, if you're a partial agonist, you can cause some hyperplastic changes. You are just so much less likely. Look at how we can summarize this here. Both tamoxifen and raloxifen behave as agonists in the bone if you are post-menopause. Of course, all this is because of being post-menopause. In the breast, both drugs would be antagonists if the breast is an estrogen-dependent type of neoplasia. In the endometrium, well, the jury is out. It is partial agonists, therefore it can have agonistic effect. The fact that raloxifen is touted as an antagonist, I'm afraid, is because it is used for prophylaxis, therefore pre-menopause. Then of course, with the endogenous estrogen still being present, it will behave as a blocker. But wait until you're after menopause, it should behave as an agonist, just like tamoxifen.